Good afternoon, everyone. It's a pleasure to welcome you to our ongoing Health in the Public Interest seminar series. It's a pleasure this week to have Elise Trott Jaramillo, who's going to be talking about some issues about Indigenous people and access to healthcare, et cetera, in the southwestern U.S. I'll let Kaylin, our student, do the full introduction in a moment. I just want to tell everyone that, as usual, the seminar will begin with the introduction by Kaylin and then last for about 40 to 45 minutes, followed by a Q&A session um, or discussion session that could conceivably last till 1:15. But anyway, that will start out with students first and then go on to the wider audience. And um, this program, the Health in the Public Interest Program, is a program that emphasizes social determinants of health. And you can see the website in the chat and look at it later if you wish. And so this seminar fits right into that rubric. And it's a pleasure to introduce both Kaylin and Elise. So Kaylin, I'll turn it over to you.
Thank you, Dr. Myers. Happy Wednesday, everybody. I hope everyone is enjoying the snow melting as much as I am. My name is Kaylin, and I am a current student in the HAPI program here at Georgetown, and it is my pleasure to introduce Dr. Elise Jaramillo. Dr. Jaramillo is a cultural and applied anthropologist studying environmental and public health disparities for racially and socioeconomically marginalized populations. Her dissertation research examines grassroots political organizing and the effects of natural resource policies on users of New Mexico's acequias, community irrigation ditches. Dr. Jaramillo has undertaken applied anthropological research on access to healthcare and insurance for American Indian seniors and implementation science studies on an evidence-based child welfare intervention. Her current research examines social and environmental influences on mental well-being associated with place. Throughout her career, her work has emphasized participatory and community-driven strategies, critical pedagogy, and knowledge sharing, and the translation of research to policy. She has a sustained interest in fostering social support and community connectedness to improve health and well-being. And with that being said, it is my pleasure to introduce Dr. Jaramillo.
Thank you. I really appreciate it. And thank you for having me to talk to all of you today. I'm really happy to be here virtually. Let me share my slides here and we'll get started. Okay, can we all see that? Okay, great. So the talk that I prepared for you all today is called Mental Wellbeing and Sense of Place Among American Indian and Latinx Older Adults. This is based on my current research, although we'll talk about some of the past research as well. So what I'm planning to talk about today, we'll do a little bit of a background on mental health inequities for rural and racial and ethnic minority adults. And then we'll talk about relationship to place as a risk and protective factor that is both significant but understudied with relationship to mental well-being, especially among the American Indian and Hispanic or Latino older adults here in New Mexico, which are the populations that I work with. We'll talk a little bit about participatory ethnographic and mixed methods research and their role in understanding relationship to place as a determinant of health. And then I'll talk a little bit about my study that uses intervention mapping to develop community-driven strategies to improve mental well-being for this population here in New Mexico. So we'll start by talking just a little bit about mental health inequities for this population broadly. Oh, let me see. Oh, there we go. No, before I get there, a quick funding acknowledgement. These are the three studies that I'm going to talk about that were funded variously by the New Mexico Water Resources Institute and the National Institute on Minority Health and Health Disparities. Okay, so when we're talking about older adults who are members of racial or ethnic minorities, the research shows that they have higher rates of depression and lower rates of diagnosis and treatment than their non-minority counterparts. And this disparity persists across treatment settings and more or less regardless of insurance status. So with regard to American Indian and Latinx older adults, the research shows that about 9% of American Indian older adults meet the criteria for major depressive disorder. And this is compared to between 1 and 5% in other samples of older adults and non-Hispanic white older adults. Among Hispanic and Latinx older adults, it's a little difficult to say because that population is so heterogeneous. You have immigrant populations, you have longer residents, you have a lot of different cultural and national backgrounds. So they vary. Rates of depression in Hispanic and Latinx older adults vary across these different identity markers. But in general, rates of depression are either similar to or greater than among non-Hispanic whites, and some populations, they're much greater. In general, and we'll talk about this in more detail, these disparities in mental health status and access to diagnosis and treatment are largely attributable to the effects of lifetime stress, socioeconomic marginalization, lack of opportunity, and then also structural inequities, particularly barriers to care, either, both structural barriers and organizational interpersonal barriers, which we'll talk about a little bit more in a minute. When we get to rural areas, the characteristics of rurality tend to compound risk of depression and lack of treatment for these older adults. These characteristics include geographic isolation and, along with that, social and demographic change. So, a lot of folks moving out of rural areas and socioeconomic marginalization. Also, insular family and community networks can be, protective, but also a risk factor. A lot of older adults, have concerns about stigma and privacy in these kind of insular communities, which we'll talk about a little bit more. And then largely scarcity of healthcare and distance from healthcare. So a lot of these rural areas, there's, a shortage of healthcare providers, and they have to travel long distances to get care. So these characteristics of rurality tend to increase the risks of depression that are experienced by rural and minority older adults. And then, as I'm sure many of you know, the research shows that untreated depression is a risk factor for a lot of negative health outcomes, including increased mortality, cognitive impairment, and various other comorbidities like diabetes, heart disease, and stroke. And this population of older adults is quite large and growing. So about 1 in 5 US adults that are age 65 and over live in rural areas. And the population of American Indian and Latinx older adults are actually growing quite quickly. So the census estimates that by 2060, the population of American Indian older adults will increase by about 40%, and the population of Hispanic or Latinx older adults might increase by more than 150%. So this population of minority, rural dwelling older adults is growing and at high risk for untreated depression and the associated negative health outcomes. When we think about New Mexico specifically, the older adults here in our rural areas have particular risk factors for mental health problems and substance use problems based in a particular history of structural and health inequities here in New Mexico that are rooted in our history of colonization. So some of you may know New Mexico is extra lucky because we got colonized twice. So the American Indian populations here were colonized by the Spanish, and then several hundred years later by the United States government. And so that history of multiple colonization has a lot of downstream effects in terms of these populations largely having lost traditional subsistence practices, being moved off their land, socioeconomic and cultural marginalization, and ongoing kind of discrimination and neglect. And this is sort of only heightened by kind of urbanization and gentrification processes that continue to take place today, and the resulting pressures on natural resources, water resources, land, things like that. So my research takes place in Rio Arriba County, which is north of Santa Fe. It butts up against Los Alamos County, which is one of the richest counties in the country, and Rio Arriba County is among the poorest. The latest estimates say that about 18% of residents in Rio Arriba County live in poverty. About 9% of those residents are American Indian. Rio Arriba County is home to two American Indian tribes, Okewinge and Santa Clara Pueblos. And then about 80% of those residents are Hispanic and Latinx, and there's a fair amount of overlap. So there are a lot of folks that identify as both Hispanic and American Indian in Rio Arriba County. And that county has higher mortality rates from mental health and substance use problems, as well as from various chronic illnesses that are associated with depression compared to state averages. So there's some pretty significant health disparities in that area. However, the rates of depression among American Indian and Hispanic Latinx people, especially in this area, can be difficult to measure. There's a fair amount of research on these populations more broadly that shows that there are differences in kind of the concepts and manifestations of mental illness that can make it difficult to get really good measures. And that also doesn't touch on issues of, trust with research and trust with healthcare that also affect our assessment of depression rates in these populations. The particular town that I work in is called Espanola, and it is also very affected by a fragmented behavioral health safety net. Behavioral health providers were largely shut down, a few years ago for a variety of reasons that were unjust and difficult for this community. And there's also a long history of representation of this community as being particularly poor, criminal, and kind of trapped in a cycle of addiction and disease. So I put a couple of national headlines here. These are all about this little town of Espanola. So it has a particular reputation as being a challenging place, and the folks that live there, are affected by and aware of their reputation as in this quite negative light, which has to do with our interest in place that we'll talk about here in just a minute. So mental health in populations in general, but in these populations particularly, are what we like to call wicked problems. So the concept of tame problems and wicked problems was described first by these folks, Riddle and Weber, who were urban designers, and then has been used by the cultural psychologist E.J. Trickett to talk about these kinds of difficult and complex problems. So the idea is that a tame problem is a problem that is easily defined, discrete, and has, pretty clear and findable solutions. And in contrast to that, a wicked problem is complex. It's hard to make a difference. It can be unpredictable and open-ended. And wicked problems can also be hard to agree on the definition of the problem and the solution of the problem. So, mental health issues in these communities are definitely what we would call wicked problems. But there's a good amount of research that shows that multi-level and collaborative solutions are really important for these kinds of wicked problems, and particularly place-focused and community-driven interventions can have a difference in some of these issues. So, as some of you may know, mental health interventions in general, and then particularly for these minority and aging populations, tend to focus on individual level factors. That's true for health intervention sort of across the board. There's a predominance of individual level strategies like medication management and helping folks navigate the health system. And they're very important. But there's a lot of, well, I wouldn't say a lot, there is some really promising research showing that these kinds of health equity issues that are rooted in structural injustices and inequities have been usefully addressed by place-focused and community-driven intervention, particularly in racial and ethnic minority settings. A lot of that research is in urban areas and urban communities. And then community level healing approaches are also quite culturally relevant for reasons that you'll see in a little bit here. for addressing the root causes of mental distress for American Indian and Hispanic Latinx folks in this community. So healing approaches that target the community as a whole rather than individuals are desirable and quite meaningful for these communities and others. So I'm particularly interested in kind of advancing the science of these community level healing approaches. So I'm going to talk more now about relationship to place as a determinant of mental health. Take a look at my time here just to make sure I'm on track. Okay. So, in talking about relationship to place, I'm going to back up and talk about a couple of other research projects that I have done. The first is research that I did with folks that are users of community managed irrigation ditches in northern New Mexico. They're called acequias. These are just images of acequias. So, this is a historical method of communal water sharing that is particular to arid and dry climates. There's a lot of evidence that indigenous folks were using this method of kind of gravity-fed and communally shared water management before the Spanish got here. But then the system that we know today, called the acequias, came with the Spanish and persists today in a lot of communities. And so it's a method of irrigation, but it's also a method of kind of community organization. So everybody that lives along the ditch works together to manage the ditch and to share the water equitably in times of both plenty and scarcity. So it's not kind of a first come, first serve model. It's like if there's a lot of water, everybody gets a lot of water. If there's not very much water, nobody gets very much water. And you can kind of see this is a map of some of the regional associations of these kinds of communal irrigation associations throughout the state. So I was doing research with folks that use these ditches. Um, and they were involved in a variety of kind of political organizing around water sharing and water scarcity. So this study really looked at the role of acequia practice in the formation of personal subjectivity, social relatedness, and political consciousness for the users of acequias. And it was an in-depth and longitudinal ethnographic study. So it used participant observation and qualitative interviews and case studies analyzed with grounded theory. So there were a variety of findings to this study, but what we're interested in today is how it pointed to relationship to place as both a risk and a protective factor for these communities. So in this research, I really saw a lot of health promotive factors associated with relationship to place and engagement with the environment. Among these, were cultural and environmental practices like irrigation, gardening, and ceremony associated with the environment. These kinds of practices were also tied to meaningful connections to family and community, and to roles of land caretaking and stewardship. So I put a quote down there at the bottom from one of the gentlemen that I spoke to as part of this research. And he was talking about his relationship to the ditch and to the environment and to his place, saying, I think it's just inbred in you because of so many years dependent on it, meaning the acequia. Your life depended on it. It's an emotional tie to something that's like your home. I don't believe anything that it's attached to only Spanish people. It doesn't matter what nationality you are. If you were raised in a place and you loved it and you worked your butt off in it and you improved it, it pays you back with sustaining you. So I like that quotation to illustrate some of the connections to family and community and the meaningful nature of land caretaking and stewardship associated with engagement with place and relationship to place. There's also I have a couple of publications that really talk in more depth about how relationship to place was related to social cohesion and helped communities maintain relationships with one another across racial and ethnic lines that I won't go into here. But relationship to place was also associated with risk factors, including historical trauma. So, especially these Hispanic Latinx communities have a lot of memories of loss. There's been a lot of land loss, dispossession, and so connection to place can be connected with very difficult memories. And there's also grief and anxiety connected to environmental and economic change. So there's, a lot of effects of climate change in these communities and increasing drought, and wildfires, flooding, those kinds of things. And so the relationship to place is powerful and important, and that can have some negative effects when it's really difficult in grief and anxiety connected to loss and change. So the second study that I want to talk about that related to place as a determinant of health is a study that we called Seasons of Care. This was a community-driven study that was initiated at the request of a group of American Indian elders that were part of the New Mexico Indian Council on Aging. And you can see those elders here. They asked me and my colleague Katie Wilging, who's there in the middle with the pink and the cardigan. Katie Wilging was the PI on that study, to design a study to understand how elders were understanding and experiencing healthcare and health insurance, particularly in the wake of the Affordable Care Act. So these elders were concerned that elders were still experiencing significant disparities in access to healthcare and experiences of healthcare and insurance, and they wanted us to help them study it. So the aims of that study were to assess how American Indian elders understood, accessed, maintained, and used insurance coverage, to characterize their experiences with help seeking and healthcare, identify and compare factors that affected their access to healthcare, and then based on those findings to develop and implement a structured intervention for outreach workers to enhance patient navigation for these elders. And this was a mixed methods study with a convergent parallel design that used quantitative surveys, in-depth interviews, and concept mapping to understand these questions. There's a number of publications out of this study if anybody's interested, and it's a complex and deep and thick issue. But I just am going to touch on again the relationship to place that resulted. So we have a variety of findings of all kinds about insurance and help seeking and healthcare experiences with these elders. But for the purposes of the talk today, I'm going to again talk about relationship to place as a risk and protective factor that emerged from this research. So again, we saw health promotive factors that were associated with relationship to place in these populations of elders, including meaningful social roles and community obligations. So very similar to what we saw with the acequia users. Some of these folks are also doing water sharing and things like that, but more broadly, there are a lot of elders that are involved in different kinds of societies. They're taking care of the church, the Kiva societies, things like that, and they have meaningful social roles and community obligations associated with their particular community and landscape. And then also connections to place-based memories and stories that they conceptualize as being quite central to resilience and survival for those communities. But again, we also can see risk factors associated with place. And of course, these are risk factors that also touch on issues with structural issues, health system issues, organizational issues, but many of them are kind of centered in these particular communities. So, for example, chronic gaps in transportation and safety net services are particularly present in these communities because of their rurality and economic insecurity. So a lot of these Native communities are far from services and have to get transportation, which they may struggle to access. Um, in the Indian Health Service clinics and hospitals in these communities, elders experienced high rates of provider turnover and perceptions of their community as being undesirable to providers. So a lot of providers at these healthcare facilities are on kind of loan repayment programs. They're short term. They're kind of coming in and out of the community, and elders really experience that as being a situation where providers didn't really want to be there. They didn't really care about the community. They didn't like the community. They wanted to just move back to the city, and they were just kind of putting in their time, which was, very painful for these elders. We also saw dense networks of acquaintanceship that sometimes stigmatized mental illness and help seeking. So a feeling that, it was hard to get help because you didn't want everybody to know your business and you didn't want everybody to know what was going on with you. And then also fear and mistrust of healthcare systems and very much particular healthcare facilities that were based in long histories within families and communities, including experiences of abuse and neglect. So I put a quote, an illustrative quotation here at the bottom from a woman that I spoke with that was talking about a particular healthcare facility in her community. This is where, all the indigenous folks in the community went for care and had for generations. And she said, I really hesitate to go see them, doctors at this facility, because they tell you you're this, you're that. Like every time I go there to the IHS hospital, they tell me I have high blood pressure. My mother, she took all these medications, and I think that they just probably affected all her whole system. And I think that's why I just hate to go see a doctor. So, we saw, several folks that expressed similar stories about family and community histories with these particular healthcare facilities that resulted in kind of fear and mistrust. So, as a result of these two studies and my particular interest in place, I developed a study that I'm working on now that looks particularly at place-based strengths and vulnerabilities associated with mental health among American Indian and Latinx older adults in northern New Mexico in the Espanola area. And so this study is really designed to kind of plumb these questions around place and mental well-being. It's also a mixed method study. First, to kind of describe the full range as much as possible of vulnerabilities and protective factors associated with the, social and environmental place, associated with depression and access to and use of mental health services for this population. So qualitatively, I'm trying to really get a sense of the range of protective factors and vulnerabilities associated with place. And then to analyze relationships between those factors and depression symptoms for this population, and compare them across axes of difference. So how do American Indian and Hispanic elders experience them similarly and differently? Looking at sort of younger elders and older elders, gender, and then access to health systems. So some folks are using the Indian Health Service, some folks are not. And so comparing how some of those differences affect the relationship between place and depression symptoms in this population. And then based on these findings, to engage folks in an intervention mapping process, which I'll talk about in a little bit, to develop a community-driven protocol for a place-focused intervention that targets the factors influencing depression for this community. So this study is based on the idea that, again, that place is crucial to mental well-being for these elders. So this is a model of wellness for rural older adults that was developed by these folks, Winterton and colleagues. You can see here the bottom circle there is the idea of wellness, so health status, emotional and mental wellness, and quality of life. Um, what Winterton and colleagues suggest is that those top two levels, the sociospatial level, which is demographics and kind of contextual factors like affluence and population density, and then the second level resources, so what healthcare resources, health insurance resources, transportation resources are available. Their theory is that the wellness of older adults is affected by the sociospatial and resource levels because those levels influence opportunities and capabilities for health and well-being. And those two levels also influence elders' perception of their community, so how they feel about their community. My suggestion and what I'm testing with this study is that while the sociospatial and resource level does predict mental well-being in the way that Winterton and colleagues suggest, in that low economic status and lack of access to resources will predict greater ill health, mental disease, mental health issues, that those relationships will be modified by community attachment and sense of place. So rather than the top two influencing the bottom two, I'm suggesting that second to bottom level, the perception level in terms of community attachment and sense of place, actually has a modifying effect on mental well-being for older adults. So that's what I'm trying to test with this study. So to do that, and I'm working with an advisory group of American Indian Latinx elders and allies and healthcare providers. As we thought about how to do this, we realized that we needed a really good way to measure community attachment and sense of place. So you can do it qualitatively, very well, but we wanted to be able to do it more broadly and quantitatively. So we started looking at measures of sense of place and community attachment, and found that what was available was really not particularly relevant to these communities of elders. So, and by sense of place here, I'm using the definition given by this anthropologist, Keith Basso. He describes sense of place as the ways in which citizens of the earth constitute their landscapes and take themselves to be connected to them. So existing measures of sense of place, interestingly, or I thought it was kind of interesting, really focus on recreational environments, like people's attachments to I think there's one that looks at like a lake where people do a lot of water skiing, things like that. So kind of recreational environments, national parks, things like that. And then also neighborhood attachment measures tend to be quite urban focused, which has some applicability to this population, but is still just not quite right. Um, and these existing measures tend to focus on three domains of sense of place. These include place identity, so the sense that your identity is connected to your place through items such as this place says a lot about who I am. Place dependence, meaning that that place is unique and that you can't find what you need anyplace else. So an item, an illustrative item there is this place provides value I can't obtain elsewhere. And place attachment. So your kind of emotional and spiritual connection to place, like I would miss this place if I moved away. So some of those things are certainly relevant to this population, but as we were developing our data collection instruments, we really felt the need to kind of take a few steps back and think about how do we assess the particular senses of place and attachments to community that are characteristic among this population of Indigenous and Hispanic folks. So we engaged, we did a couple of characteristic community-based participatory research exercises, which my department here at UNM focuses on community-based participatory research. And so we did an exercise called All on the Wall, which is an exercise where folks respond to kind of a focal question by writing sort of every thought that they have in response to that question on individual sticky notes and putting them all on the wall, right? So I asked the elders and providers that I was working with, how does place affect mental well-being for older adults in this community? And they came up with, as you can see, lots of different answers. And then we spent a good amount of time thinking about how to categorize all of those ideas into different domains of sense of place and community attachment, which we then distilled through kind of an iterative process that I won't go through too much into a set of domains for analysis. So these are the final domains that we came up with after kind of going through them and going over them multiple times. You can see the domains across the top. So in addition to these kind of ideas about place identity and place dependence, the domains that they identified to analyze were social connections through place, security, obligation, landscape and environment, and rootedness. And then you can see there in the gray boxes the constructs within those domains and a sample item for each construct. So within social connection, we have relationships like I share meals with people that I know and like. Gathering places with a sample item like there are places in my community that I can go when I want to see people, and social change. So items like I worry about the ways this community has changed. We also have the domain of security, and that includes safety. I worry that crime in this community will hurt me. Privacy. I feel that my neighbors are watching me or know too much about me. And representation. So a sense of feeling that the laws where I live are designed to protect me. Then we see a domain that we called obligation. So a sense of stewardship. I have a responsibility to care for the land and natural resources where I live, and caretaking. I have an important role in this community. Next was landscape and environment. And within that domain, we have connection to landscape and environment, like spending time in this landscape gives me strength, and sample items around landscape and environmental change, like I worry about changes to the plants and animals that I used to see here. And then finally, rootedness. Um, Items around memory, places around here remind me of things I have lost, and items around stories. I know stories about this place that give me strength. And the hope with this measure, so we developed sample items and we tested them with cognitive interviews, which are interviews where you kind of give the questions to folks and allow them to sort of free associate about this is how I would answer it and why, that give you a sense of whether the questions are asking what you want them to ask. So we did rounds of cognitive interviews. We now have a final instrument. And in quantitative surveys with American Indian and Latinx elders, we're giving this sense of place measure and a kind of modified neighborhood attachment measure that we decided was the best one that was out there that was validated. And so then we're going to analyze, how well those two hang together quantitatively. So hopefully come up with a really good sense of place and community attachment measure for what we're calling land-based people. And the hope with this measure is that existing measures of sense of place tend to just measure it along kind of strong to weak, right? You either have a strong sense of place or you have a weak sense of place, and it's somewhere along that spectrum. Part of what we're interested in is not just strong to weak, but also positive to negative, right? So with these communities that have had this long history and tenure of dwelling in this place and a real connection to place, you can conceive that there are folks that have, a strong positive connection to place, where it's, I lived here, my family's lived here, it's meaningful to me, it gives me strength, I have a role, I have a meaningful responsibility, right? So you can see a very strong positive connection to place. And you could also conceivably see a weak negative connection to place, right? Like I just live here because I have to. It doesn't mean anything to me. I don't like it. I feel isolated, right? But then you can also see the other poles, right? So you can see folks that might have a strong but negative connection to place. Folks that have a long history there, but they've lost land, they've lost people they love, they see climate change, and so the connection to place is really one of kind of loss and grieving for them. And then you also see with these kind of places where folks are moving in and out, like a strong but weak connection, right? I don't have a history here, but I like it and it feels good, right? So the idea is to try to understand both those axes of attachment. Okay, I'm almost done here. So the assessment here that we're doing, the data collection is part of an intervention mapping approach. And I'm just going to very briefly describe intervention mapping. I'm sure some of you are familiar with this approach, but it's a participatory approach for planning health intervention. So the idea is that instead of kind of choosing an intervention and then applying it to a community and doing cultural adaptation and things like that, you start from community needs and desires, and then through a participatory process, identify change objectives and intervention strategies for those change objectives. So the first step of intervention mapping is a needs assessment, and that's what I've been describing as the data collection. We're also using a method called ecological network analysis that I won't talk about here for now. And then based on that analysis, you work with participants to create a model of change. So as we review all the data as it comes in, working with community members to think about a model of the problem and a model of change. We then identify change objectives and select strategies to achieve those change objectives. And I'll show you some examples here in a second because it's hard to conceptualize abstractly. And then based on those selected objectives and strategies, then you then develop and test materials, design an implementation plan and an evaluation plan, et cetera. So this is a table of sample change objectives for a community-focused, place-based intervention around depression for these populations. This is based on the Health Disparities Research Framework of the National Institute of Health Disparities. So you'll see across the top there levels of influence. So whether you're influencing the individual level, the interpersonal level, the community level, and the social level. And across the side there, domains of influence. And so the kinds of change objectives that we're thinking about with this study and intervention are those middle two rows there in the blue. So intervention strategies that affect the physical, built, and sociocultural environment. And so you can see how some of these things might work. So for example, if you wanted to do a community focused intervention strategy on the physical and built environment, that might include looking at increasing the number and quality of community resources, including public transportation, green spaces, and access to mental health services. A community-focused intervention on the sociocultural environment might include shared spaces for reflection about colonial histories and their effects on mental wellness. So I won't go through each of these in detail, but you can kind of see how as we think about the findings of the research as they come in, we can think about what kinds of strategies and what domains are most pertinent for addressing the influence of place on mental well-being. And then finally, you can see some kind of sample intervention methods that are community-focused intervention. These have, good findings and good results in the literature. For example, the idea of health zones, where folks are engaged in finding leaders and aligning resources to transform root causes of health risks. Community action coalitions are really focused on engaging community members in more research and coalition building and action planning. Learning circles is a strategy that's been used to do cultural exchange and knowledge sharing kind of intergenerationally, which I think is pretty interesting for older adults. And deliberative dialogues is an approach that's been used to help folks to do consensus-based and collaborative decision-making around how spaces are used. So these are just examples of the kinds of methods that are available to us as we think about the intervention that we're developing for this community. And I think, yeah, I think that's where we're gonna end. So where we are right now is we're collecting the data. And so in the next couple of months, we're gonna get together with all of our community partners to review the data and start thinking about what our intervention targets and methods will be. So that's where we are in that study. So I think that's where I'll stop for now and leave space for questions. Let me stop my share.
Yeah,
Okay.
perfect. Thank you so much, Dr. Jaramillo. That was an amazing presentation. So as Dr. Myers mentioned, we will start with gathering questions from my colleagues here in the HAPI program, and then once there are no further questions, we can move on to general audience questions as well. So,
Great.
and feel free to type in the chat as well.
Okay, while we maybe wait for students to gather some thoughts to come up with some great questions, which I'm sure they will, I have a question on, I guess, perspective. Um, so native populations, of course, have a really deep and long-held connection to their environment, whereas much of the rest of our nation, at least, people don't, right? As you've said, that there are both positives and negatives in terms of what people get out of their environment. Do you think that this kind of study would also be useful to perform in other parts of our society?
Um, Thank you. Yeah, that's a really good question. I do think so. And one of the things that I'm interested in is, New Mexico is a particularly interesting place, at least to me, because um, particularly in this area, the Native and Hispanic Latino populations have, in many ways, I don't want to say more in common than they have differences. I mean, I do sort of want to say that, but I don't want to necessarily quantify it as more. But there's a lot of commonality. These are historic Hispanic populations primarily that have been here a long time, mixed in with more recent migrants. So one of the things that I'm interested in is how applicable it is to some of these other populations that I think. Right now we're kind of calling land-based people. So, people who are really, either make their living through the land or are connected to land, culturally and historically. And there are, I think, other populations that this would be interesting too. I think about like Appalachia comes to mind. Um, Places where folks have kind of historic residence but have experienced kind of subsistence changes and land loss. So I think it is in particularly rural spaces, potentially applicable to other communities. Um, and I think I'm interested in sort of pulling out what some of the implications are of sense of place, both connected to but separate from like a particular cultural identity. So yes, I mean that's a question that I'm interested in exploring.
Oh, thank you.
Hmm.
Looks like Taruni has a question.
Hi, thank you so much for your talk. That was very interesting. Actually, me and a few of our other classmates did some research on rural healthcare access. So this was really interesting to kind of understand a very specific culture. My question was a little bit about the next steps of where this research would go. So I know you're talking about you're still looking at the results and figuring out, how to implement some of these changes. Do you see there being a difference in like incorporating more culturally responsive care, like outside of the community? I know there's a difference between like the Indian Health Service and then rural, like community hospitals, but do they already have some of that cultural training in the Indian Health Service? Or like, is it more receptive already to like implement like changes that would come of this kind of research? I'm not sure if that was a very clear question, but
No, I think I understand what you're saying. It's a good question, and it's complex. I think we're hoping to, pull out some of that information, especially through the qualitative interviews. In this area in particular, there are providers that do more kind of culturally responsive care. With the Indian Health Service, obviously it varies from facility to facility, but if folks are going to find culturally relevant mental health care, for example, IHS is a good place to look for it. Um, we're also asking folks about kind of different sources of care. So traditional healing, um, non-professional healing, things like that. So I think we're hoping to get a sense of what is available to folks and what they're actually accessing and why, um, in order to kind of hopefully build on some of the strengths that are there, and then find some gaps, that may also be there, especially in terms of kind of culturally responsive care. Yeah. Um, does that answer your question?
Yeah, thank you.
Yeah. So yes, I think there is some, and I think we want to know more about it and kind of capitalize on what's there that's already strong and also address some of the gaps. Yeah.
Okay, and we can move on to Noah.
Hi there. Thank you. Thank you again also for your talk. That was very interesting. Um, my question has to do with a little bit more of the qualitative interviews that you were discussing.
Mhm.
So my fellow happy colleagues and I were in a class that's focusing specifically on qualitative interviews or qualitative research. We've talked about surveys and interviews and things like that.
Mhm.
Um, Specifically when it comes to creating research or creating qualitative questions and interviews that are sensitive, that are intentional, that are ensuring that are coming off in the right way in order to not just elicit the right responses, but to make sure that you're getting as much of the information that you are looking for and also that they're willing to give. So I'm curious in the formulation of those interview questions for this study, what were the most important things that you and your team had to keep in mind when creating them? And were there any challenges and how did you handle those?
That's a great question. And I am happy to talk about qualitative research all day because that's my wheelhouse. So it's a great question. And it is challenging. And actually, depression is a particularly challenging thing to ask about because the variety of kind of words and concepts and ideas around depression and sensitivities around depression. So just going out and saying, like, are you depressed and have you experienced, whatever, is challenging. And you don't really know what you're going to get with a question like that. So, what we're doing that I think has been successful so far, and we'll kind of look back on it when we finish all the interviews, but what I feel good about with the interviews that we've done so far is, and I wish I could attribute it off the top of my head, but I found a model for an interview topic guide, and I really wish I could come up with the author off the top of my head because I feel bad not giving them the right attribution. But it was a topic guide for qualitative interviews focused on depression. And instead of laying out questions, it started with kind of a broad discussion of like, what's good in your life? What makes you struggle in your life? And a lot of other questions. Tell me about your background, tell me about your family. And as you have that conversation with people, identifying through their own language the way that they talk about when they feel good and when they feel bad. Um, and as they talk about it, then using the words that they use to kind of narrow in on, so like when you feel bad or when you're struggling, what is that like? And what do you experience? Um, and so not really using the word depression or sadness or whatever, but allowing space for the interview participant to develop their own vocabulary around it and then to use their vocabulary in inquiring more about it. Um, I had not really seen that approach used very often. You mostly just see like a list of questions. And I think that's really promising and something that I want to develop further. Um, because I think there's a lot of value in allowing space for interview participants to kind of set the terms and vocabulary of the interview themselves. So we're experimenting with that with this set of interviews around depression, and yeah, so far I think it's going well, but I'm curious to see how it continues. Does that answer your question?
Yeah, absolutely. I actually have a follow-up question if you don't mind.
Yeah.
I was wondering, so that makes total sense and allowing that space I think is probably so helpful for the interviewers and the interviewees, of course. Um, Do you feel like there's been any other lessons that you've kind of learned throughout the way that you've changed? Because I know that happens a lot in qualitative research. As you're kind of going through the process, things change, things, tweaks are made in the way that you're going about interviews and your approaches. So I'm wondering if there were any other things that you felt like your team has had to change along the way in the process to better tailor to the group that you're interviewing.
Yeah, that's a really good question. I mean, so there's certainly questions that kind of, tend to elicit crickets, that we sort of have cut out or modified. I'm trying to think of a good example. I mean, one area that we had to do some tweaking is we found that in asking some of the questions around like, do you feel safe in this place? And would your neighbors help you in an emergency? Kind of things like that, that folks were quite tended to go down the path of like emergencies, break-ins, which is important, and what happens in those situations, like whether the ambulance comes or whether the police come or who's watching out for your house and those kinds of things. But then it was really difficult to switch gears to talk about like resources that are available in the community. So when we would ask questions about, what kinds of, if you need help, where do you go for help? Folks kind of then would still talk more about like, well, if I call the police, they don't come, or if I whatever. So it was like trying to get at some of those other aspects of like community resources and things like that was took a little extra tweaking to get those answers that we wanted. So, we observed, as I said, that there was kind of a uh, like a gravity to some of those questions about like emergency response that obviously was really important. Like that was something that like everybody wants to talk about, which is important in and of itself. But then also figuring out how to find out other stuff was important as well, if that makes sense.
Yeah, absolutely. Thank you so much for sharing that.
Sure.
Oh, I'm not seeing any more
Hmm.
questions from.
Kaylin, sorry, I
Yeah, sorry.
can't find the raise hand function.
You're good.
Yeah, no, I was very struck, Elise, about your what you were saying about the attitudes towards Indian Health Service,
Mm,
which um I experienced a very long time ago as a medical student in a remote Indian reservation, Eagle Butte, South Dakota.
mhm,
And what I thought was really interesting there is like the doctors I worked with were some of the best doctors I'd ever worked with. But it was extremely demoralizing to them, the attitudes that the patients had, which was that the IHS doctors were butchers sent by the government to kill them.
mhm.
and far as it would be from my perspective to say trust everything your doctor says, like there's problems on both sides of that relationship that I just think are worthy of study.
Yeah, that's very interesting. And, there's some interesting research out there. And again, I'm having a hard time coming up with it off the top of my head, but um, there's interesting research in Native communities that show, and this was our experience as well, is that folks largely like and trust their providers, but they don't trust the system, right?
System,
So there's
right?
institutional mistrust, right?
Hmm.
Which is, I think, an important distinction. And because, you can train providers all day long and should, excuse me, but how do you address that institutional mistrust that's rooted in a real history? I mean, obviously, I know that like Native women were like forced to be sterilized. I mean, there was bad stuff that happened in these clinics, um, and a lot of folks both have memories of those things, stories of those things, and also family experiences of like, misdiagnoses and, people didn't believe me and, these things happened. And so that institutional mistrust is hard to target in part because it's both pragmatic and it's affective, right? It's like, even if I can get the care I need, I have this emotion around it and I have this feeling around it. And so like, how do you affect that is a complex question. Yeah.
Perfect. I'm not seeing any other questions at this moment. So I can go ahead and turn it back over to Dr. Myers. I think he has some final words just for the rest of us.
Okay, and if there are additional comments or questions, feel free to either put them in the chat or follow up whatever I have to say here with those comments. Elise, I want to thank you for joining us today. It was just me paging through department faculty at various places close to Native American populations where I happened upon your bio, and it sounded really interesting. I know you really fairly early on in your research efforts. I think you finished your PhD defense just a couple years ago. Is that right?
Oh, well, almost 10 years ago now,
10
2017.
years. Okay. Well, time flies when you're doing research, I guess.
Yeah.
Anyway, I'm struck by a lot of what you said about the your relationship with the community. We've heard a lot this semester and previous semesters about the need to engage the communities and make sure they understand what they're getting out of the research, and also that they can identify with the people who are doing the research. And, this is maybe a little more of a subtle question than I want to ask, but in your situation where you're still a couple steps removed from eventually somebody's going to do health interventions or treatment interventions, access interventions, whatever. How much harder is it to engage the community and develop their trust for you compared to, let's say, somebody that wants to do a water study and then propose some things to ameliorate the problems?
Um, Let me clarify. Are you asking in terms of like how much more difficult is it in terms of like doing exploratory research versus like a more applied or
Right. Well, yeah. What you're doing is you're defining your research methods, defining your problems. You're not just going in with a proposed solution
Correct.
and presenting it to a community, right?
Oh, yes.
Um, what, so we've heard quite a bit about community participation and research and getting the buy-in of all the parties, et cetera. So do you think it's more difficult in what you're doing to develop that trust and buy-in, or I don't know, what's your
Mhm.
experience with that?
Yeah, I see what you're saying. Well, it's a good question. So, excuse me. I wouldn't say, I mean, let's see. I wouldn't say it's difficult in terms of like coming up against a lot of barriers, but it is time consuming and involved. So, I think I, I'm fortunate enough to have some pretty long-term relationships with folks in these communities. When I first started doing this research, I had the support of other researchers that had long-term relationships in these communities. So I've had a couple of really important mentors that, when I was just getting started, were, there to kind of vouch for me and bring me in and say, they already had these good relationships, and so they were able to bring me in, and I was able to, ride their coattails, right? Because I
Hmm.
had them to vouch for me. Then now I have these longer term relationships that are sustained over the course of multiple studies, right? So it's not, I think there's a lot of capital in I am here, I'm not going anywhere. These are my long term partners over multiple studies and funding cycles rather than I just came in to do one thing and then I'm gone.
Right.
Um, I think that is where people can be quite cautious, and for good reason. Is there is not interest in people dropping in for one study, getting a couple of deliverables and then taking off. I think, people are savvy on that. They don't want to do that. They're not involved in that. But they are interested in getting answers to their questions if they can kind of be in the driver's seat, if they can feel that their interests are going to be represented and that the data is going to be sort of for their use. I think that folks are really quite interested in that. Let's see. But it is a long-term thing. So, I mean, I live here. I am not going anywhere. You know, this is my community. And it is harder when you have to kind of come and go and you don't have longer term relationships. I think that can make it harder. Um, but I do think that folks are very interested in an approach to research that is, I'm putting my skills at your disposal to answer questions that are important to you, and in a collaborative process that where the power is kind of shared. Um, I think folks are really quite interested in that, if that answers your question.
Yeah, that makes perfect sense. And I guess one way of restating that might be that what people who come in and do an intervention and hope it works and leave are facing is skepticism because they aren't part of a long-term relationship and they're
Yeah.
not going to be back to see how things worked out. But in research like yours, you're developing those relationships from the beginning and becoming a partner in all of this and a long-term resource, which I really like your answer to that. Okay, so again, I thank you. And if there are any last minute questions, put them in the chat or raise your hands. Otherwise, I'll turn this back to Kaylin to close it out. And thanks to everyone for attending today and look forward to seeing you next week.
Yes, thank you, Dr. Jaramillo. We really enjoyed your presentation. And yeah, if there are no further questions, I hope that everybody has a wonderful rest of the week. And we will see you next week.
Thank you very much.